As we speak about pituitary gland imaging, MRI is the study of choice, and we'll go through technique, normal appearance, and then abnormalities. And let's start just with the routine brain MRI. This is a protocol, I think, in modern MRI imaging. This would be kind of the backbone of the protocol that we need to know for any brain MRI. And we always have this volumetric sagittal T1 gradient echo image, which you can reformat then in many planes. You will always have some kind of a combination of T2 weighted images. We use at least 2 planes in each study, and with some either fat suppression or not, as you can see in this axial T2 study that has fat suppression, so the dark signal on the subcutaneous soft tissue, and then compared to this coronal T2 without fat suppression, where you see the high signal in the fat. If indicated, we can give contrast and then do, of course, post-contrast T1 sequences. The other sequences that are in our routine studies are the T2 dark fluid, the susceptibility weighted imaging, which basically highlights substances that cause increased susceptibility in MRI, like gross calcifications or blood products, and of course the diffusion weighted imaging. Basically for the pituitary gland, actually these sequences are most important. So as I said, for any indication, we do a routine brain study. We prescribe a Sella dedicated study really only when we're investigating for endocrinopathies, or you get an orbit, and of course the Sella region goes into the orbit study also when you have neuro-ophthalmologic abnormal exam. So what will be actually a dedicated Sella protocol? It will have just a lower field of view, higher resolution to the Sella region with usually sagittal and coronal planes, pre and post contrast T1 and coronal T2 images. So when we talk about the normal pituitary gland, we saw beautifully the anatomy, and what is very nice is we can see it so well on the MRI study. We can differentiate very nicely between the anterior pituitary gland, the adenohypophysis, and the high T1 signal neurohypophysis. I actually have a nice story about that, which I heard from my mentor in Emory Atlanta, Professor Patricia Hudgens. In the early days of MRI, when we just started scanning, the radiologist would dictate the normal appearing fat within the posterior aspect of the Sella. And then the neurosurgeons came in one day and just said, "What do you mean? I mean, there is no fat in the Sella." And then sure enough, it turned out that the neurohypophysis itself has this very bright T1 signal, which is felt today to represent just because of the function, the large amount of vesicles, and it's probably related both to the fatty content in the membranes and to the high protein content within those vesicles. What is really important is just to make sure there is a normal signal, because abnormal signal can be associated with pathology. We always assess for the stalk, and we want to see a normal optic chiasm anterior and then the hypothalamus posteriorly. Just as a rule of thumb, when we look at the pituitary stalk, it should not be thicker than the basilar artery. It's easy to say in children. You know, we're not talking about adults that may have some dolichoectasia and things like that. And then we also look, of course, at the Sella itself, the sphenoid bone, which in children will be bony with red marrow. And then as development pursues, we start to get this high signal intensities on T1, which basically reflects fatty infiltration, pre-pneumatization process. And then the older children and adults, we have a nice pneumatized sphenoid sinus. When we give contrast, we actually lose the differentiation, the nice differentiation between the adeno and neurohypophysis, but we do get a better delineation of the stalk itself. On the coronal plane, we want to look at a normally situated and built optic chiasm. We want to see the stalk in midline with no displacement. And we also assess for the symmetric appearance of the cavernous sinuses. We see here a flow void in the cavernous segment of the ICA. When we're talking normal in children, we need to know the age. It changes tremendously during development. And in infants, the pituitary gland is actually large, convex, and with high signal. Actually, the younger the child is, if you scan preterm babies, the higher the signal in the adenohypophysis. It could be similar to the neurohypophysis, and that will be normal for that age. As children grow and go towards 2 months of age, this mini puberty subsides, and we start getting this normal concave appearance of the adenohypophysis, which will measure usually between 2 to 5 or 6 millimeters in height in the midline. And then as children proceed towards puberty, we start seeing this pattern, which we call transition, where it abuts the diaphragm sella and measures about 5 to 6 millimeters in height. And of course, when they hit puberty, the pituitary gland become, again, convex, large. This is a post-contrast study. You note maybe that the infundibulum looks a bit thickened, but you need to take into account when the pituitary gland is very high, it can push upward a little bit the stalk and may look somewhat thickened. So just make sure not to call pathology when it's still normal. And then as we grow up, we become, again, we have this concave pituitary gland. Of course, you need to take into account, as we mentioned before, also the gender. And what this graph shows is the difference in volume between girls and boys. The gray zone is girls. We look at the pituitary volume and see in puberty age. In girls, it changed dramatically faster with higher volumes. And all these changes are really related to the adenohypophysis, as the posterior pituitary doesn't add much to that. So when the indication is an endocrinopathy, a very common indication is growth hormone deficiency. And actually, most of the studies will be normal. This has been shown also, for example, in this study, where we evaluated 192 children that were sent for growth hormone deficiency. Only 15 had an abnormality. None of them had a tumor, all were some structural abnormalities. The more severe the growth hormone deficiency is, then we tend to see some changes like the what we call empty Sella, which I specifically don't really like the word empty. The Sella is never empty, but you get this higher content of CSF and very flat adenohypophysis that can measure below 2 millimeters in height. And then as we go into a more severe endocrinological status, like not isolated growth hormone deficiency or maybe panhypopituitarism, we start seeing more abnormal pathology and also congenital anomalies, which the most common one is ectopic pituitary. Andrea said you never saw one, but we actually every year see one or two at least. So ectopic pituitary is really noticing that there is no normal T1 signal in the neurohypophysis in the posterior sella, but then we look up and there it is. So we find that normal bright signal in the neurohypophysis up at the hypothalamic eminence. And this is felt to represent lack of descent during the embryo life. The adenohypophysis itself can look either quite normal or, like in this case, can be hardly discerned and very dysplastic. What is important in these children is always to evaluate the whole neuro brain and spine axis for other anomalies. So, for example, this patient, the ectopic pituitary, was actually an incidental finding when the child was assessed for tethered cord and a large intrathecal lipoma. This 1.5-year-old female, when we looked at the brain, had this heterotopic gray matter adjacent to the ventricle, and this 5-year-old male had a large pineal cyst, which we followed later. This was a recent and puzzling case for me because here is an ectopic pituitary gland. We don't see any stalk, but then what is this? There is almost like another neurohypophysis within the sella. Lucky for me, this study was just published in 2020, and they actually described a series of 6 cases and basically coined it as another part of the spectrum of these ectopic changes. This is another case of a 10-day-old with panhypopituitarism. And, there's no normal signal in the neurohypophysis, but we do not see also an ectopic hypophysis. And then we can see a stalk, maybe like a hair-thin stalk within place. Looking at the brain of this child, there was no septum. So this is septo-optic dysplasia. For those of you with sharp eyes, you may notice that there is some abnormality of the cortex, and this child had bilateral polymicrogyria. And this was basically panhypopituitarism and dysfunction of the hypothalamic pituitary axis due to septo-optic dysplasia, which is a known association. Another congenital anomaly is a duplication, which is very rare, only case reports, where you can actually see two stalks, two pituitary glands. These can actually be well functioning, but usually come to be diagnosed because these patients have very significant facial abnormalities. And like in this child, we can see this persistent craniopharyngeal canal. When we assess for excess hormone production, for example, this is a 6-year-old girl with precocious puberty, and looking at the pituitary gland, it looks completely normal, but for those of you with sharp eyes, you might notice that there is this nodule extending down from the hypothalamus, and this is a hypothalamic hamartoma. This is a 16-year-old female with hyperprolactinemia, and we can see here on the coronal T2, T1, and post-contrast T1 a round lesion with high T2 signal, isointense to the gland and the T1 pre-contrast, and then hypoenhancing compared to the gland. On the post-contrast, there is this displacement of the stalk, and this is a microadenoma. To call it a microadenoma, it needs to be less than 10 millimeters in diameter. I think, and I'll come back to that later, this is one of the only indications where you really have to prescribe contrast from the start when you're looking for an adenoma. Pituitary stalk abnormalities. So this is a 6-year-old boy with central diabetes insipidus. So not surprising, we look at the neurohypothesis, no normal signal. And then even without contrast, we can see that there is extensive thickening of the stalk. Post-contrast, it enhances profusely. This was had a biopsy and was found to be Langerhans cell histiocytosis, as Andrea mentioned before. For this type of pattern of abnormality on imaging, there is a differential diagnosis. This can be seen with infectious or granulomatous disease, like in this case of a 7-month-old with Candida basilar meningitis. We can see here the thick and enhancing stalk, but also the enhancement goes along to the basilar cistern, the prepontine here, and suprasellar along the blood vessels of the circle of Willis. Also in the differential diagnosis or lymphocytic hypophysitis, germ cell tumors, and metastatic disease, like in this case of an 11-year-old boy with metastatic glioneuronal tumor, we can see extensive enhancement around the stalk and the pituitary gland, also extending elsewhere in the subarachnoid space. As we move to space-occupying lesion, and was mentioned before, we look at the location, the anatomy, and then try to give the differential diagnosis related to that. As you will see, the larger the lesion, to pinpoint the origin is a little more difficult. For intracellular mass, this is an 11-year-old boy with hyperprolactinemia. And we can see this, even without contrast, we see displacement of the stalk, and then we give contrast and we see this large lesion extending into the cavernous sinus, causing some narrowing of the ICA. And this is, of course, again, an adenoma, just above 10 millimeter in size, and this is a macroadenoma. I would say that the non-functioning adenomas are the ones that tend to become very large and actually present more with abnormal neuroophthalmologic exam, but those are so rare in children and more common in adults. This child was treated conservatively, and as you can see in this 3-year follow-up, this lesion started to shrink and then involute and then almost completely disappear. So actually the most common intracellular mass would be at cyst. And if we look at this 2.5-year-old girl and we just see this low T1 signal nicely delineating the space between the adeno and neurohypophysis, this is basically the region of the pars intermedia, and I would just call this like part of the anatomic variability of the pituitary gland on MRI. But this area does tend to fill with fluid. Like in this 3-month-old girl, we can see here it's a little larger. It has low T1, high T2, so this is a small cyst. And what do we do with these cysts? People are using the name Rathke cleft cyst and pars intermediate cyst interchangeably, and these apparently are hard to differentiate both on imaging and also sometimes histologically. This is a work that was published in 2019, and they actually looked at the prevalence of these cystic structures in modern day MRI and found that it can be very high, up to 60% of normal kids having brain MRI. Normal, I mean no endocrinopathies, no symptoms related to the Sella region, can have small cystic structures. They found the size to be, the maximum linear measurement was somewhere between 3 to 12 millimeters. I think one of the important things was that always the shortest axis was in the anterior-posterior plane, which can be helpful in our assessment. So as you can see, it can look a little more complex. If we look here on the left, this is a small cyst, but it has a more complex appearance with high T1 signal, but no enhancement. As we go to the right, we see a child with a little larger, rounded cyst that has, this is a T2 sequence. It has this little nodule of decreased T2 signal, high T1 signal, and then no enhancement. Many publications state that this is actually the pathognomonic appearance of Rathke cleft cyst. And of course, there is a range. This is a set of images from the StatX site showing us all of these were called Rathke cleft cysts. They can be quite large, as you see here. This is a case that was felt to be a cranipharyngioma, was resected and found to be a Rathke cleft cyst. So in my experience, I found out that if I state in my report Rathke cleft cyst, it caused somewhat anxiety in the referring physician. So for all those small little cysts that I think do not mean anything, I would just call them pars intermediate cyst and leave it be. But for those that look larger, more complex, I would call it a Rathke cleft cyst. I think it's just important to have good communication with your referring physician so they know what you mean. And of course, to assess with your endocrinology team. So this looks quite different from everything else I'll show you till now. And this is a large bilobar mass in a 7-year-old boy with diabetes insipidus and central hypothyroidism. And we see here in the middle between these two cystic structures, which is just different signal intensities because of protein content, it enhances. The CT shows us these gross calcifications. Of course, this is a cranipharyngioma, which actually it is more common in the suprasellar region. In imaging, we use the rule of 90. 90% will be cystic, 90% will have calcifications, and 90% will enhance in the wall or in the soft tissue part. This is another girl, 9-year-old girl with short stature, and we see this, that on T1 signal, it looks like a soft tissue mass. When we do the T2 and the T1 post-contrast, we actually see this as a cystic mass, just with high proteinaceous content, and it also has this gross calcification, and this was a cranipharyngioma. I just want to say today that if on your routine study you have also SWI imaging, then you can actually, in many cases, say confidently already on the MRI that you have calcification and not blood products. And this is 7 years follow-up after surgery and radiation. This is kind of a typical appearance of the residual, kind of residual amorphic, very stable mass after treating these patients. Okay, this is a different patient, 3-year-old boy with FTT, and because of new onset headaches and vomiting, was presented and had a CT that showed the hydrocephalus and the large mass with gross calcifications, probably slow growing. As you can see here, this deformity and impression on the Sella region. And this is the MRI showing the areas of cyst, areas enhancing, and this child had surgery. Surgery with partial resection, and this is the 3-month post-surgery follow-up study. which basically demonstrated quite increased, very fast growth within this tumor. I just want to point out that this child also had multiple CSF drainage complications, which I'm not going to address in this talk, but were treated all along the treatment period. So because of this regrowth, child had another surgery, another resection. Within another 1 month, again, a growth was seen. Child was sent to proton radiation treatment and came back with this kind of residual cyst, almost no solid enhancing portion, just enhancement in the wall. And then as we continue to follow up, we see in the next follow-up, about 2 months after the initial study after radiation, we see growth of this cyst. And we also see some enhancement in the brainstem. So this was felt to represent maybe post-radiation still changes. And we continue to follow up. And then finally, we started seeing shrinkage of this lesion. However, as we see this shrinkage, we also noted something happening with the vessels in the circle of Willis. And this child has started developing this narrowing of the ICA vessels. On continued follow-up, good news, the craniopharyngioma have finally got to this little amorphic residual mass, which is stable. However, this child has went ahead and completely closed their distal ICA and MCA. You can see in this MRA study, here you can see the ICA, you can actually see the MCA. Here is a very thin-like ICA, no supraclinoid ICA, no MCA. And what you see here is recruitment of external carotid arteries that supply the brain. Lucky for this child, already had multiple craniotomies and places for the brain to call for blood vessels. Here you see an angiogram from the external carotid artery just showing ECA branches supplying the brain itself. This is a T2 dark fluid sequence showing the high signal in the salt site consisted with the IV sign that we recognize with moya-moya disease. So basically, this child developed radiation-related moya-moya. Here's another case of a 9.5-year-old girl with headaches and vomiting, and there is this large heterogeneous mass in the suprasellar region. Is this a craniopharyngioma? Well, there were a few things that made us think that there is a differential diagnosis here. First of all, on the diffusion-weighted imaging, there was some restriction we don't see usually with craniopharyngioma. And both on MRI and CT, we saw some blood products, but we didn't see gross calcifications. And this turned out to be a germ cell tumor. These are two cases, a large suprasellar mass, looking very different from each other. Both came in with headaches and vomiting. This 1.5-year-old had this high T2, low T1, and profusely enhancing mass. This 4-year-old had this very heterogeneous appearing mass. On the T2, it has this layered appearance. The enhancement is mostly peripheral. However, both had an optic chiasmatic pellucitic astrocytoma. This is a 5-month-old boy with FTT and feeding difficulties. The anterior fontanelle was still open. An ultrasound study demonstrated the enlarged ventricles due to this echogenic mass in the suprasellar region. MRI showed again a very heterogeneous enhancing mass. And when we look at the axial images, we actually note that there is also leptomeningeal enhancement, which we do not, we're not so used to see in these kids. And this turned out to be an astrocytoma, but a mixed pilocytic and high grade. And this is following, this child is still being treated. The mass is after surgery and chemotherapy and has decreased in size. So I basically showed you how enhancement helps us to better recognize the different masses and tumors. But I do want to have your attention just for one more minute to talk about gadolinium a little bit, because what is gadolinium? Gadolinium is basically a metal which was made, is toxic to human beings, that was made safe by touching into a ligand. And, you know, the first time we saw problems with gadolinium was when NSF, everybody knows what is NSF, nephrogenic systemic fibrosis, a debilitating skin disease that was found to be related to gadolinium injection in chronic renal failure patients. This was addressed with change in practice, checking GFR and not giving gadolinium with patient on dialysis. And basically since 2009, no reports about this new onset disease. However, in 2014 and 2015, there was a report showing us that there is increased T1 signal in basal ganglia and dentate nuclei in patients receiving multiple administrations of gadolinium. Today, we know with multiple additional studies, both in animals and human beings, that definitely this is related to gadolinium retention. So we became aware that gadolinium is retained in body tissues, also in the brain. Since multiple publications assessing for possible related pathologies have failed to show one, in 2016, a very serious radiologist, Professor Semelka, who is actually author and editor of the MRI body textbook, have looked at a group of patients claiming that their life was destroyed after they had an MRI with gadolinium. And he coined the term gadolinium deposition disease, and I think that in the next decade we'll start seeing works trying to assess for this connection. So of course FDA and other advisory committees are very, you know, quick in warnings, in publishing warnings. Always the warnings are more severe for children and pregnant women. And then I love this, where they're saying minimize repeated GBCA imaging studies when possible, particularly closely spaced MRI studies. However, do not avoid necessary GBCA MRI scans. So what should a pediatric radiologist do? So I think the main point and what we'll be seeing in the next decade is really not to avoid necessary, so when is it necessary? I think we need to stop doing this automatic brain with and without contrast. I think we need to really know when is it indicated. This is a very nice study from Germany. They looked through almost 7,000 brain MRI studies of children. They gave the radiologist to read it without contrast and decide if it's normal, abnormal, and give a diagnosis, and then they let them read it with the contrast. They basically found out from those that were read as normal, only 0.3% had additional pertinent findings with the contrast. And that was mainly related to leptomeningeal enhancement. So basically, if we do an MRI study, there is a pathology, we probably need to give contrast to better delineate that pathology. But if the study is completely normal, in most cases, the contrast will not add anything. This is a study just now published 2021, looking at patient assessed for endocrinopathies. I think as I showed you, in most pathologies of endocrinopathies, except for adenomas itself, we can do the diagnosis and we don't really need contrast unless a mass is present and we want to better identify. And they're showing that it is actually safe to do these studies without contrast. And also this, I mean, you know, tumor, we always say, of course, with and without contrast, but for optic gliomas, this work actually raised the question, okay, we do a diagnosis, we have a full study with and without contrast, but do we need these children get every 3 months, 6 months, or a year, depending on the rate of growth, a study? Do we really need to give them in each follow-up study, again, contrast? And the answer here was actually no, because they found that the actual changes in enhancement pattern didn't really change the treatment decisions related to these children. So I just think we'll be seeing more and more works about this, about when to inject and when to not. Of course, the problem is that for that you need a radiologist sitting online on these studies, checking them and deciding to give or not to give the contrast. So this is the way we practice. I know that many places, due to lack of personnel, that maybe is not possible. So with that, I would just say that MRI is the imaging technique of choice for the pituitary gland. We saw that the pathology can range from signal changes to space-occupying lesion. And I think as a pediatric radiologist, our role is to suggest a diagnosis when it's an ant, meaning give a logical differential diagnosis when it's not that typical, follow treatment response, and identify complications. And with that, I thank you for your patience.